Is Dr. Rohit Loomba, professor of medicine at UCSD, very renowned in terms of NASH, NAFLD research and clinical care, and he's the founding director of the NAFLD Center at UCSD. And he's going to talk to us about the fatty liver abstracts from AASLD this year. Thank you.
Thank you, Jeff, and the organizers for inviting me. Delighted to be here. So these are my disclosures. One thing I did was I looked at the agenda, and you have a lot of guidelines updates. There is a non-alcoholic fatty liver disease guidelines that will be coming out anytime in the next few weeks. Most likely it'll be in January or February and published in Hepatology. So I have some preview of those guidelines, and I want you to have that so you can actually utilize them in your practice as you go back next week. So these are some broad outlines that I thought I should cover, and I'll end with AASLD, NAFLD practice guidelines, and I won't, spend we can spend 2 hours just discussing guidelines, but maybe the key things that are changing is what I will discuss today. Globally, as you know, about 1 billion people have non-alcoholic fatty liver disease. There's a clear ethnic predisposition in Asian Indians. It's much more common than Hispanics, followed by Caucasian, and then African American are protected. Risk factors include metabolic syndrome such as obesity, hypertension, hypertriglyceridemia, insulin resistance, and diabetes. We all know that. What about certain genes that increase the risk for having NASH, cirrhosis, and also hepatocellular carcinoma? There are many, but there are 3 important ones that we all should remember. PNPLA3, TM6SF2, and MBOT7. This is where we have the greatest evidence. And now we have treatment in trials where we are knocking down PNPLA3. So if this gene is causing liver problems, if we silenced it, could it improve NASH? We're not discussing that, but hopefully next year we'll have some abstract that'll be looking at gene silencing treatments for NASH, as we are seeing in alpha-1 antitrypsin right now. There's another gene called the HSD17B13 that protects you. So you may have thought or seen there are patients who have a lot of risk factors but really don't develop liver disease. And why is that? Potential explanation is about 7 to 10% of people are just protected from liver disease, and despite increased risk, they don't develop progressive fibrosis or cirrhosis. And potentially, this is also being utilized now as a treatment for NASH-related fibrosis, but it may also be useful across the board for other causes from liver disease as well. Now, how do we diagnose NAFLD? I think it's good to have a definition as we get into this discussion. It's diagnosed either on a biopsy or imaging evidence of hepatic steatosis, where at least 5% of hepatocytes are infiltrated with steatosis in individuals who have little or no alcohol without any other cause for liver disease or hepatic steatosis. This is one abstract on genetics that was presented at AASLD from the Michigan group. And what they did was they pulled in data from multiple previous studies where we had genetic data and some sort of a liver phenotype. Liver phenotype could be on imaging based upon CT scans or other such as UK Biobank. There was MRI available, and in certain they just had classification of whether somebody has fatty liver or not. And in some of these, you also had data on cirrhosis and other manifestations. So they pulled in all this data, and then they came up with various pools within these patients with NAFLD, and tried to divide them into genetic-based categories. Now, they're not, you can see them in this way, but you can also lump them because all our patients don't come up with one problem. Usually, when a patient has fatty liver, they also have hypertriglyceridemia, they also have diabetes, they have other metabolic risk factors as well. But this is one way of looking into things and where we can classify where there might be different genetic pools of abnormalities that could be pulled in as one. So if it is, difficulty to turn over lipids from the hepatocyte, and there are certain genes associated with that. There are certain genes associated with improving insulin sensitivity or glucose. And there are different genes that are not associated with any of these, but may be very divergent. And those may be related to inflammation or fibrosis. There's one more gene in this called MARC1, where we are also developing new therapies related to it. So as I told you, there are at least 3 genetic targets in NASH and fibrosis where we might see new treatments coming along. Now, this hit did not recognize HSD17B13. So you can see all the studies, despite a large sample size, do not get us all the answers that we need. But this is a good start in terms of thinking about when we want to combine things and also assessing our patients in future. What about non-invasive assessment? What is new in 2022 is also what I'm going to cover, because I looked at the agenda, I thought this will be useful. And many of these are coming into the AASLD practice guidelines. So one question we all have, patient comes in to see us, and just imagine that we have a therapy that you can use for treatment of NASH. Now, how can we see the patient without doing a liver biopsy, know that this patient can be treated with a therapy and a payer will pay for that? Well, that requires that the patient has NASH with stage 2 fibrosis or higher, and we should be able to detect that with pretty good certainty. So there is a lot of activity in that domain. There are 3 tests that we're going to discuss. FAST is one. So this includes CAP on FibroScan machine, VCT or liver stiffness on FibroScan, and serum AST. You combine that and you can get a score, and based upon that score you can see the probability of this patient having NASH with stage 2 fibrosis. There's another score that basically takes that on MR, MRI PDFF, MR elastography, and AST called MAST, and then a score called MEFIB, which is pretty simple. Basically, you do a FIB-4 first. If the FIB-4 is 1.6 or higher, then only you spend the money for the MR elastography. So you're saving a lot of money. And if the MR elastography is 3.3 kilopascal, you got 97% positive predictive value. So I'll show you some data. FAST is good, but anything on a ultrasound-based modality may not give you that high a positive predictive value. As clinicians, we all want positive predictive value to be high. So you do a test, it's positive, you really want to communicate that to the patient that you actually have disease. The problem comes when you have a very low positive predictive value. So test is positive, somebody else tested the patient, now patient is in your clinic, oh, my test came positive, so I'm here to see you. So like, they should have never tested you for this because you had a pre-test probability that was too low. Now we're in a soup because it's 50-50 right now. And that's the problem with FAST that you can have. So a FAST of 0.67 or higher can have a positive predictive value that ranges from 0.33 to 0.83. Now, how can we improve upon that? Well, I think if you think about metabolic risk factor, if you knew even before going in that this patient really had NASH with stage 2 fibrosis, then you confirm it, you're probably going to have a pretty high positive predictive value. But if you were randomly just doing everybody a FAST, and then that's where you're going to have a problem where a lot of patients would be brought in but may not have the disease. Now, if it is below 0.35, you have a pretty low likelihood of having a significant disease. Now, in Madrigal trial, I presented that data, and briefly I'll show. We looked at this. If you had 1,000 patients with biopsy-proven NAFLD coming in who had stage 2 fibrosis and NASH, we have to lower this criteria so we don't miss those patients. So in our clinical practice, it's different than if you start looking at 1,000 patients. For a clinical practice, you really want certainty, and that's why for that particular patient, you want to use the higher cut point. Otherwise, you're more likely to be wrong. Just to improve upon that you want a positive predictive value of 95, 97%, we looked at it carefully as to what are these factors that are important. And we looked at all clinical factors that were available. And we wanted to develop a simple test. And the simplest thing is if you combine a FIB-4, which is 1.6, so anyone below 1.6, you don't have to do the MR elastography is what I'm saying. So you saved a lot of money already. Then you do the MR elastography if you have it, and it is 3.3 kilopascal, you're looking at 97% positive predictive value in Southern California and validated in Japan. So this can be used. Both of these are now in the practice guidance as tools for your clinical management. So it's not something that we will not be seeing in our practice. Then we also did a comparison between MEFIB, MAST, and FAST for detecting fibrosis. This just came out in JHEP. It's just showing that MEFIB is better than the other two tests in terms of detection of fibrosis. But I think you can use any of these. The idea is that whichever test is available to you, you understand how to use those cut points and then utilize them in your practice. Of course, if you do MR elastography, you may have a much stronger positive predictive value. We also recently published this data combining 6 different cohorts, and 2 of those from Southern California, looking at MEFIB at baseline and also MR elastography at baseline and long-term clinical outcomes. Here we are showing that if you were MEFIB positive, the test that I just showed you, so you had a patient, 1.6 FIB-4 and 3.3 kilopascal, that's the blue line in the bottom where there's risk. Let's see here. So this is MEFIB positive patients and this is MEFIB negative patients. So if you're MEFIB negative, for 5 years, you don't have any clinical outcomes. So it's also safe that, if you identified a patient like that, you're not going to be worried that this patient is going to be in trouble. This study also defined that, what do we call cirrhosis on MR elastography? And the answer is 5 kilopascal. So if you are 5 kilopascal or higher on MR elastography, that patient has cirrhosis. And what is the diagnostic accuracy we're talking about? We're talking about 90-95% accuracy. So when you get that reading, it has a pretty good value. If it is 8 kilopascal or higher, you definitely want to do an endoscopy on that patient because that patient is a pretty high risk for bleeding. So that also helps. So if you randomly got a patient consult, they got an MR elastography, 5 kilopascal or higher, you want to start doing all the things that you do for a patient with NASH cirrhosis or any cirrhosis. This is a recent abstract that one of our fellow, Nabil Noureddin, presented at AASLD, where we just looked at those who are MEFIB positive and those who are MAST positive, long-term clinical outcomes, and compared those. And what Nabil found, again, MEFIB performed very well. MAST also performs okay, as you can see. So you can use either of these tests. Of course, you would need an MRI PDFF to calculate MAST. So if you don't have that, you can utilize MEFIB because you have FIB-4 in everybody, and if you had MR elastography. Now, previously, others have shown, and we also had a paper looking at just liver stiffness on FibroScan and long-term clinical outcomes. Those cut points are different. We can discuss in question and answer session if you have exactly what cut point to use in your practice for those. But those came out much before this year. So I'm only covering what's new this year. This is just comparing MEFIB to MAST, showing superiority, but overall you can use either of these tests. Now, there's always a question, you do an MR elastography, somebody else does an MR elastography, how does it pan out? Do the results match? And so we have a very large study called Goldmine. It's in 21 different sites all over the world. And we get central data reads and we have local reads. So we are comparing our local reads with a central automated read, and showing here that you have a pretty high concordance with the local read. You can do better than that, so 0.98 for what we're doing here in this particular study. And the reason for this study is we're looking at MR elastography, biopsy, FibroScan, and all the serum-based biomarkers and long-term clinical outcomes in this study. We are planning on getting 1,000 patients. We already have 450 in it. So no paper. This is the first one now, and this study's been in works for 5 years. So next year we'll start having publications from this cohort, and just showing that both results are valid, and you can do an automated MR elastography reads that work very well. Now, who to screen? New data in terms of that. There was a recent paper that was presented at EASL and also published in JCI. And the question is this. You saw a father, 65-year-old, with NASH cirrhosis in your transplant clinic. And the father is sitting next to his son, who brought him to the clinic. And you're evaluating the father for liver transplant evaluation for NASH cirrhosis. What is the son's risk? So this study answers that question. And the risk in the family first-degree relative is 15%. So we had 100 probands of NASH cirrhosis from Southern California mainly. And we had a lot of patients with NASH cirrhosis from LA who came down, and we did advanced MRIs on them. Many of your patients in this room. And then we scanned their first-degree relative. It could be just 1 or 10 first-degree relatives. And we found that the prevalence was 15%. And then we validated these data in Finland with a cohort that was similarly ascertained by our colleague in University of Helsinki. So risk is pretty high. And now the NAFLD practice guidance is saying that we should screen first-degree relatives for presence of advanced fibrosis. Now, that was not in the previous guidance, so this is something new that has been added. There was another paper that actually just came out in JHEP and was also presented at AASLD by our faculty, Viral Ajmera. This is a R01 that I have where we prospectively evaluated another group. So diabetics, 50-year-old, there is no data to say in the United States prospectively that what is the rate of advanced fibrosis or cirrhosis in a patient population with type 2 diabetes. Now we have some data from NHANES, but nobody's prospectively looked at that with that clinical question. So we did this study in primary care and in endocrine clinics, the 50-year-old diabetic. I think age is important, although in the NAFLD practice guidance, we haven't specified age, but age is always important when you start screening. Again, my issue is that you should have a high enough risk and proportion of patients who've got that problem before you start randomly screening them. So I think it's fair to screen a 50-year-old diabetic because the risk for advanced fibrosis is 14% based upon either MR elastography or FibroScan. If you want both of them to be positive, then it's 10%. So still 1 in 10 has advanced fibrosis, and we found about 29 patients who had cirrhosis, 2 with HCC, and 1 with gallbladder cancer. This is 500 or so patients. We're still continuing that study. How often do we follow a diabetic? We're answering that question with a follow-up of this study where we'll bring these 500 patients back over 2 to 5 years to see what rate of progression we see. This was another paper. This was a plenary talk by Daniel Huang in our group. He's a visiting scholar, a transplant hepatologist from National University of Singapore. He was spending 2 years with me. And in orange, we have patients within the NASH CRN who have type 2 diabetes and had 2 biopsies. And in the green, we have patients who do not have type 2 diabetes, have biopsy-proven NAFLD, and had 2 biopsies. So we have paired biopsies, and we're looking at fibrosis progression rate. Previously, about 7 years ago, we published that in patients with NASH, it takes 7 years to go from one stage to another, thinking if things are linear. So when you're seeing a patient asks you, doctor, I'm stage 1 fibrosis today, how long will it take me to progress? So, well, majority of patients, if they were to progress, it will take 7 years for one stage. You can say that to your patient, but what if they were diabetic? Is the rate different? And here we are finding the rate is different, and you would have faster progression if you were diabetic. The reality is the progression is going to be even faster in a community-dwelling diabetic compared to this cohort because our mean hemoglobin A1C is below 7 in this cohort, even if they were diabetic. So these are very well controlled within the NASH CRN sites in United States. Typically, if I'm seeing a diabetic, they have a hemoglobin A1C between 8 and 10, and so their risk of progression, I think, will be higher. What about treatment? Well, we have lots of therapies in NASH that are being assessed, and many have failed, but there are certain that are still in works. Here are some therapies that are in phase 3, called resmetirom, obeticholic acid, semaglutide, and now we have lanifibranor. We may be getting new data on resmetirom top line anytime soon. This is a thyroid hormone beta receptor agonist. I'll discuss some other data that came out this year, and I think it's important. This is looking at the REGENERATE trial, which was obeticholic acid 25 milligram versus 10 milligram versus placebo, and the results are in the bottom. I'm showing you fibrosis improvements to the left, which is 23% versus 12% of placebo. So 25 milligram dose does improve fibrosis. You know, it seems low, but these results tell us that you can improve fibrosis due to NASH within 72 weeks. And these results are consistent with the previous phase 2b trial. NASH resolution results were not consistent, and so you can see that there is no significant improvement, although there's a numerically increased NASH resolution with obeticholic acid. Main issues with FXR is efficacy-wise, you have a treatment effect delta of 11-12%, and no NASH resolution that we are seeing. Side effects, you know, there's an LDL increase. There is new data that after 48 months, it actually comes back to normal or where they started from, so it comes back to baseline. We still have to study that. Pruritus, there is dose-dependent pruritus that patients get, typically about 90 days or so into treatment. It's dose-dependent, so if you lower the dose, you can improve the pruritus. There are certain hepatobiliary issues. FXRs increase the risk for gallstone formation. So if a patient is on obeticholic acid, comes with right upper quadrant pain, which is severe, you know, we have to take it seriously. First thing you want to do is stop, and you may have a patient with PBC who may present with that. So one thing that we all should consider, if somebody is on an investigational treatment in NASH, they come to the ED for abdominal pain, stop all IP. There is no need for them to be continuing their investigational treatment as inpatient. Whatever they have, they can resolve it. They can start IP after they get discharged. That will save a lot of problems, because these drugs, such as FXRs or other bile acids, they have intrahepatic recirculation. So once you've got a gallstone blocking your common bile duct, you're going to start actually having much higher levels of these drugs within the hepatocyte. It might induce hepatotoxicity. So it started with a gallstone event and led to, you know, bigger problem for you and the patient. So the remedy for FXRs, I think we will probably hear a lot more, because the paperwork has been is getting ready to be submitted to FDA for the consideration for approval for this drug, because there's a lot more data on safety and also on efficacy now. This is data on semaglutide. I added this because we all are seeing more and more use of semaglutide in our clinical practice. To the left, I'm showing you that semaglutide is better than placebo. This is 4 milligram once daily. This is not the dose that we'll be using in our clinic. We're going to be using weekly dosing, probably 2.4 milligrams sub-Q. And no improvement in fibrosis shown to the right over 72 weeks. The main issues, again, is efficacy-wise, you can see NASH resolution, but no improvement in fibrosis. Side effects, there are GI side effects, typically in the first 16 to 20 weeks. Once patients are able to tolerate that and go through it, then, you know, people are good. In the last, I think, 2 days, I've met 4 different people. They were not my patient. They're all on semaglutide. I also think many people in this room might be on semaglutide. You don't have to tell me, but I know you are. Now the remedy, and it's a good thing. I think it's a good thing. The remedy is a combination approaches, because semaglutide is going to improve NASH resolution, get you to the right weight, but you might need other therapies to improve fibrosis. But this might become the standard of care, either this or tirzepatide, which is another Lilly drug that we'll be discussing probably next year in early disease in obese and overweight NASH patients who are diabetic. This is looking at resmetirom data in well-compensated cirrhosis. Stephen Harrison presented that. This was important because this thyroid hormone beta receptor agonist appears to be safe in patients with advanced disease, and you don't have to modify the dose. So this is important because if you think about obeticholic acid or FXRs, we've got to modify the dose as you develop cirrhosis. And so it's important to exclude those patients if you're exposing them. So that's one issue with FDA as to how do we decide that patients are going to be safe. So with resmetirom, there is good data on non-invasive improvements, but also good data that it appears to be safe in those who have cirrhosis. So there was a series of presentations looking into different aspects of this. Phase 2 data has already been presented earlier, where we showed there was significant reduction in MRI proton density fat fraction, something that we developed at UCSD and now being utilized in about 100 trials all over the world. This particular drug, within week 12, it lowers liver fat, and that correlates with 9-month improvement in histology. So this is helpful if you want to see which patients are going to respond to treatment. The phase 3 top-line results will be available anytime now, and so look forward to hearing those and discussing that with you in coming months. This is looking at another drug, which is a fatty acid synthase inhibitor, denifanstat, where we showed improvements in liver fat to the left compared to placebo that are pretty significant, both absolute and relative reductions. And there's a responder assessment that we've done. So question, if you saw a reduction in liver fat, does that correlate with improvement in histology? So the idea is if you saw a 30% reduction in PDFF, which is what we call as MRI PDFF response rule, you have a 5 times higher odds of improvement in histology in terms of NASH resolution. So this is how we're translating. If we see benefit, then we go into a biopsy-based trial with drugs that have an anti-steatotic mechanism. So this drug shows that, and now this is in a phase 2b trial. We'll have results next year. This is showing ALT improvements. We had previously shown that if you had a 17-unit decline in ALT, that's also associated with a histologic response. So if you combine both ALT and MRI responses, do you improve your histologic response? And we have data that you do, and it jacks it up to 10 times higher odds of histologic response. This is looking at FGF21 efruxifermin data, which was presented at AASLD. This is the trial design, 2 different doses, 28 milligrams sub-Q weekly and 50 milligram versus placebo, and a biopsy was done at 24 weeks. These are the results, fibrosis improvement, both in 28 and 50 milligram relative to placebo at 20%, and significant NASH resolution rate. Again, there's a clear response on PDFF that correlates with NASH resolution in this study as well. This is combined response with both fibrosis improvement and NASH resolution at week 24. And then 2-stage improvements were also seen in about 15% of patients. So this is likely to move to a phase 3 program soon. This is looking at pegozafermin, which is another FGF21 analog. This is an uncontrolled study and data we presented, 32% NASH resolution, 26% 1-stage improvement, and 47% had at least either of these improvements. Depending on studies, these are not head-to-head comparison. the drugs appear comparable on MRI-PDFF responses. This is looking at AASLD practice guidelines that I talked about. So the key issues now we're saying is, you will use the FIB-4 in your clinical practice. If it is 2.67 or higher, then you can use VCT, ELF, and we didn't put in here, but you can use MR elastography as well. And based upon that, the patient will be referred, and then you can further risk stratify the patient in your own practice. This box is GI and hepatology care. There's a slight overlap, but recommendation would be sort of a broad screening of those who have type 2 diabetes and metabolic syndrome. We already talked about how best we can identify who needs to be treated. This will be also in the practice guidelines, but we discussed those parameters already. These are some of the non-invasive parameters. These slides will be available to you also for your use later on as the meeting notes. The key things here are listed. Statins are safe and recommended for cardiovascular risk reduction in patients across the disease spectrum, except in decompensated cirrhosis. But there is limited data in that setting, so we don't recommend that. Now, the patients who have stage 2, John, you brought that point, and so we added this. Those who have stage 2 fibrosis or higher should abstain from alcohol. Then we also have new data that ALT improvements and reduction in liver fat is associated with histologic improvement. And then the first degree relatives of NASH cirrhotics to be screened has been added. So there are a lot of data that came out from Southern California that has actually changed this clinical practice guidelines. So thank you, and happy to discuss later.